of you for this Neurology Forum case discussions. And I have great pleasure in introducing Professor Dhanraj, the chairperson of today's meeting. Professor Dhanraj is a consultant neurologist at Apollo Hospitals. He is formerly professor and head of the Department of Neurology at Stanley Medical College. He is a meritorious student, both in MBBS as well as MD. And he was one of the earliest persons to obtain MNAMS and was ranked first in the TNPSC of his batch. Professor Dhanraj is my immediate senior in DM, and hence I know him very well during his course of DM as well as afterwards when he was assistant professor and later reader. He's a thorough clinical neurologist, very methodical and meticulous, a fantastic clinician, and he was a pet of all the four great teachers who were our teachers: Professor Jagannathan, Professor Arjun Das, Professor Krishnamurthy Srinivas, and Professor Zahir Ahmed Syed. He, in fact, the first stroke unit in a government hospital was established in Madras Medical College, and Professor Dhanraj was put in charge. He was in charge of the first stroke unit in the entire Tamil Nadu in a government medical college. Later, when he moved over to Stanley Medical College, he revamped the epilepsy clinic over there, which was set up by Professor C.U. Velmurugendran, and did phenomenal work in the epilepsy clinic at Stanley Medical College, as he had done in the stroke unit in Madras Medical College. He is a prolific writer, has a number of articles, number of publications, number of chapters, and has also edited books. And that is Professor Dhanraj for you in short. Sir, Professor Dhanraj, you can now take over and start the proceedings, sir. Thank you very much for coming and taking over. Thank you, sir.
Thank you. Thank you very much, Dr. B. Natarajan here.
You can start the proceedings, sir. Call Kishore.
Okay. First, I think I should introduce Dr. Kishore, Professor of Neurology, KAP Medical College, Trichy, I think. I welcome you all. I think you are going to speak about your interesting case about ophthalmoplegia with facial palsy. I am sure it will be interesting. I request Dr. Kishore to come up. Hello.
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 Yes, sir.
Yes, please proceed.
The respected Professor Dhanraj sir,
Yes.
chairman of today's meeting, respected Professor Natarajan sir, the organizer and coordinator of this meeting, and my dear friends. In the previous lectures, you would have heard very long, complicated cases. But what I am going to present you here is just a short case, very short case. It's a case about facial nerve palsy and ophthalmoplegia. You might be wondering what's interesting in this case, and you also might be wondering what is the rarity in this patient. Quite often you see many patients of facial palsy day in and day out, almost 4 or 5 cases per month, or at least bifacial palsy at least in a year or so. And similarly ophthalmoplegia, quite often you see. But what is rarity in this patient and what is interesting in this patient? So I hope you might not have seen patients with bifacial palsy with ophthalmoplegia together. It's quite rare. With this brief introduction, let me start the history. This gentleman, Mr. 42 years old, Mr. Sundar, he started to notice watering of right eye first, followed by deviation of angle of the mouth to the left side. Initially, he had difficulty in, as like any other patient. Initially, he had weakness of the right side of the face by closure of the eyes, and there was deviation of angle of the mouth to the left side. The next day, as usual, he didn't consult anyone. The next day, he started similar complaints on the left side. There was difficulty in closure of left eye, and there was stasis of food on vestibule of the mouth, and there was slurring of speech and drooling. He consulted a physician, and he was prescribed acyclovir 4 times a day and low dose of steroid, and he was advised physiotherapy, which the patient did for next 15 days. Even 15 days later, his facial muscle power did not improve, but he started to have pain over the right orbit and periorbital region. This pain got gradually increased with eye movements. He also noticed double vision on looking to either side. There was increasing swelling of the right eye and in around the eye. The patient started to experience pain, and at that time the patient, there was drooping of eyelids. He also noticed the eye had become very prominent and protruding than the left eye, and there was complete drooping of right eye. He also felt that he could not roll his eye on either directions, in all directions. There was no other history, significant history in this patient. As like any MBBS, first DM students, first year student will say, there is no facial numbness, no swallowing difficulty, no masticating difficulty, no, everything was no weakness of the limbs, no weakness, no wasting, nothing. Only he had bifacial weakness and ophthalmoplegia. Is that okay, sir?
Kishore, Kishore, can I ask you something? When you say the right eye was swollen and prominent,
sir,
was there a proptosis?
Yes, sir.
Proptosis. I think
Proptosis was there. He said.
How
about the eyes as such? Was there congestion of the eye? Was there tearing of the eye?
Yes, sir.
That was also there.
Yes, sir.
And pain over the face?
Which one, sir?
Any pain apart from the orbital region? Was there pain over the face?
There was no pain.
But he did have headache.
No, mild headache he had, sir.
Okay, this points to an involvement of either at the brainstem level or most likely at the brainstem level, because the facial nerves were involved apart from the ophthalmoplegia. I would think of two sites of possibilities, two sites. One is the brainstem, and the other would probably be a cavernous sinus also, extending backwards to involve the facial nerve, though that's a bit unusual. But otherwise, the proptosis and the painful orbital, painful orbit and the painful facial involvement with a headache would also make me consider a cavernous sinus problem, particularly because you said there was congestion and tearing. But the facial nerve involvement bilateral start with takes the lesion to the brainstem primarily.
So it's a bilateral facial pulse.
Yeah, so I would think of a problem there. So we would have to consider an inflammatory lesion, possibly a demyelinating inflammatory lesion. Of course, findings wise, we'll have to see whether he had ataxia also. So possibilities would include an inflammatory lesion which unlikely to be infective, but probably a demyelinating lesion like Miller-Fisher syndrome, though facial nerve involvement is not common, but it can happen. These would be my thinking.
Sir,
Others are
proptosis
welcome.
is
Others
very
are welcome to discuss.
and painful. In Miller-Fisher, it will be usually painless.
Sir, others
how-
are welcome to discuss, sir,
How,
please.
how was the how is the sensation over the face?
Facial sensation is normal. There is no loss of sensation.
Corneal reflex?
Sir, that will
Yes,
clinical.
come to the physical finding, I think.
Okay, sir. By facial weakness, he had only facial weakness. There was no retroauricular pain, no loss of taste sensation.
Yes, Anand, you can tell what you think. So also Justin is there, Meganan is there, some of the senior people are there.
Sir, I would, since the facial nerve is involved along with the extraocular movements, I would think of apex of the orbit syndrome going into the petrous temporal bone.
Then how would you explain bifacial weakness?
Vijayan, Justin, you're all silent. So also Meganan answer. AVS also can take part.
Hello?
Lakshmi, yeah. Sir, Dhanraj sir, நீங்க சொல்லுங்க.
Leila, I have some interesting things. I feel that he had probably had got a facial palsy plus extraocular palsy. But what is the most interesting point in this patient is the retroorbital pain, which is unlikely in most of the non-specific conditions, and plus proptosis. I think presence of proptosis plus the retroorbital pain, it is more suggestive of an extra-axial lesion extending from the anterior cranial fossa to the middle cranial fossa on both sides of this one. So this is an infiltrative lesion here, I think, both sides in view of the bilateral element facial palsy plus ocular palsy. We still do not know which are the ocular muscles involved, and there is the presence of proptosis showed. There is literally probably an infiltrative lesions here involving both the cranial fossa, anterior and middle cranial fossa. The nature of the lesion, we'll have to find out. Maybe it may be an inflammatory lesion. Maybe it may be even one of these so-called pachymeningitis lesions here. Some lesion which is occupying the space could be considered.
Sir, Kishore sir.
Sir,
Sir, how old? Sir, I am late to join. Sir, what is his age, sir?
42 years.
Diabetic, sir.
Non-diabetic and non-normotense.
Sir, as Professor Dhanraj sir said, it is an extra-axial lesion compressing the. There is from the anterior cranial fossa, it goes to the middle cranial fossa. It has involved third, fourth, sixth cranial nerve. As you said, extraocular movements are absent with the bilateral vision. Probably inflammatory or infective pathology, granulation issue. Either it may be a tuberculosis or it may be due to a sarcoid, which can pick up the bilateral facial nerve as the same sitting with the involvement of the that is apex of the orbit that involve the nearby the cavernous structures that is coming up. Another close differential is there any underlying aneurysm which is called pulsatile headache is there? You have to find it out, sir.
Inflammatory lesion is a good suggestion, sir. In fact, but
Inflammatory, infiltrative lesion, both
Yes,
sides.
yes, sir.
Yes. As you said, the DD could be a granulomatous lesion like sarcoid, tuberculosis, the fungal. It could
Yes,
be
sir.
a hypertrophic pachymeningitis.
Yes.
It could be anything, but distinctly presence of proptosis and pain puts a structure infiltrative lesion. Yes.
Even
Justin,
yes, sir.
only thing is, see, it was very short duration. First
Yes,
day,
sir.
left
1.5
sided
months
facial
duration.
palsy.
Sir,
Second
1.5
day,
months, sir.
first day right side facial palsy, second day left side facial palsy, and within 15 days he goes on to develop the ophthalmoparesis.
Yes, sir.
Yes, sir.
So we need to consider that the duration also.
Yes, sir.
Certainly, a meningitic process, an
Yes, sir.
inflammatory meningitic process, extraaxial is certainly possible,
Yes,
but it
sir.
is ultra short for that extensive lesion. Though possible, yes, certainly. But we'll have to give credence to the duration.
Sir, even IgG4 disease also can pick up like the multiple cranial.
yes.
Sir, may I come in?
Please.
Yeah, Vijay.
Sir, only thing, as Professor Dhanraj had pointed out, the proptosis gives away the lesion definitely at the superior orbital fissure. So if there is proptosis and ophthalmoplegia, painful ophthalmoplegia, there is a lesion in the superior orbital fissure, no doubt. Now, the second thing is he's got bilateral facial palsy. Now that's intriguing. Now it's very difficult to localize these two together now. If it is an element facial palsy, I think these things should have been considered separately only. My mind goes to infiltrative, maybe even leukemia should be given a thought. A chloroma sitting in the superior orbital fissure, causing a superior orbital fissure syndrome separately and causing bilateral facial palsy. Of course, basal meningitis, tuberculosis, everything would come into.
In other words, multiple cranial neuropathy.
Yes, sir. But I don't think we can localize both the lower motor cranial facial palsy and the SOF syndrome to the same site. It's very difficult. So definitely he's got a superior orbital fissure. The proptosis gives away that.
Or it can be in the cavernous sinus.
Sir, yeah, it could be in the cavernous sinus. But only thing, sir, the good old Paul Bryce says the difference between cavernous sinus lesion and
Sorry, Vijay, it broke off.
superior orbital fissure lesion is only proptosis. Just splitting any. Thank you.
So, Kishore, what did you think and what happened further?
Sir?
Proceed, Kishore. What were your thoughts and proceed with the findings?
Okay, sir.
Sir, Dhanraj sir, our proceed panlama.
Yes, I think we can proceed. Please proceed. You can tell your working diagnosis at this point from the history and proceed.
He was a non-diabetic and a hypertensive, and he had clean habits. There was no history of fever. There is no fever, and the history of recent marked weight loss for 8 kilos was present. On examination, there was swollen faces with fullness in orbit and periorbital region.
What was
puffiness
your
of face.
thinking?
He had bilateral, non-tender, diffuse parotid enlargement.
Sure.
Yes, sir.
Professor Dhanraj is asking a question.
What was your working, your diagnosis when based on the history? What did you think?
Sir?
What was your thinking based on the history?
So, please repeat. It's not audible.
Kishore, Professor Dhanraj wants to know what was your thinking at the stage of the history.
Sir, actually this patient has got bifacial weakness and unilateral total ophthalmoplegia with proptosis. So the first possibility is either all the eye movements. According to the history, the patient says he could not move the eye on either side, on all the side. So possibly all the three cranial nerves being involved, third, fourth, and sixth. So such a possibility occurs only in either in the cavernous sinus or in the superior orbital fissure or in the orbital apex. It could not be a space occupying lesion because we have to correlate bifacial weakness also. It should be some form of inflammatory lesion. That's what we thought.
The ophthalmic paresis was unilateral, not bilateral, sir.
Yes, sir, unilateral, sir.
Oh, bilateral. Okay, thank you.
It's a unilateral ocular pulse.
Okay.
Only on the right eye.
Okay, proceed, sir. Proceed, sir.
Sir, on examination, he was conscious oriented, higher functions were normal. His left eye, acuity of vision, field of vision and color vision was normal. On the right side, it was 6/36 with hazy media with few hemorrhages. And pupils were normal, reacting bilaterally to the light. Both direct and consensual right reflex was normal. Examining the right eye, there was complete ptosis of the right eye, proptosis of the right eye with more than 3 mm protrusion in mid position. It was axial protrusion, proptosis, and it was non-pulsatile. Chemosis was present. His right eye was totally immobile. Adduction, abduction, elevation, depression, and rotational movements could not be possible. The pupil was normal in size and it was not dilated. Left eye, all the ocular movements are normal, pupils were normal, and chemosis was present. This is the picture of that patient showing complete ptosis, fullness of the face, and chemosis. On opening the lid, as you can notice the eye in mid position with chemosis and biparotid diffuse swelling. You can notice the fullness. Fifth cranial nerve examination, there is no weakness of muscles of mastication. There was no facial sensory impairment in all the three divisions. Corneal reflex was interpreted to be normal bilaterally, as the patient could feel the corneal sensation as he retracted his head while examining. He has right ptosis, and left side there is element 7th facial nerve palsy. So corneal reflex could be interpreted indirectly only. The impression is that both sensory and motor functions of the 5th cranial nerve is normal. Facial nerve examination, there was typical element facial weakness on the left side. On the right side, indirectly we could make out with the smoothened forehead, drooping of lower lip, absent eye elevation. Bell's phenomenon could not be made out in this side due to ocular motor weakness. Taste sensation and lacrimation was spared in both sides. Other cranial nerve examination was within normal limits, and there was no demonstrable spinomotor weakness, sensory involvement or incoordination. All his motor reflexes were normal and there was no bladder or bowel involvement. Summarizing the findings, he has unilateral non-pulsatile axial proptosis of the right eye with bilateral chemosis, right complete external ophthalmoplegia involving right 3rd, 4th and 6th cranial nerves with sparing of pupil, normal 5th sensory motor, bilateral element 7th involvement and bilateral diffuse paratidomegaly.
General examination did not reveal any glandular swelling, any axillary, cervical, any other part.
Sir?
General examination, there is no lymphadenopathy, is it not?
Sir?
I don't know whether I'm audible. There
Hello,
is
sir?
no lymph node enlargement, is it not? Cervical, axillary, groin.
Kishore,
Sir?
Professor Dhanraj wants to know whether there was any lymph node enlargements anywhere.
No, sir. No lymph node enlargements.
Categorically not palpable, and absolutely no lung involvement, no history of cough or anything like that.
No, sir.
Can you tell us more about this retinal hemorrhage?
Sir, actually, there was a choroidal detachment
Bilateral?
with hemorrhages.
Unilateral or
Right.
bilateral? Kishore, was the hemorrhage in the retina unilateral or bilateral?
Unilaterals.
One test did not show any papilledema, is it not?
No papillodemas. Right eye could not be made out, sir. On the left side, no papillodemas. Right eye media was hazy. You could not make out the fundus. On the left side,
Can anybody discuss this patient with the physical finding?
நீங்க பாருங்கடா டேய், நீங்க பாருங்க நான் அந்த வரேன்.
Again, what is striking is, apart from the bilateral facial, there could be a number of causes. What is striking is the unilateral ophthalmopathy is complete with proptosis and with retinal hemorrhage, and it's an axial proptosis, suggesting something is pushing from behind. And the retinal hemorrhages and the overall picture seems to suggest that it was not only unilateral, the chemosis was bilateral with puffiness of the face also on the right side, which is very clear. So, in some way or other, the anterior cavernous sinus is involved. Whether it is due to a deposit which is situated there, which is pushing the eye, causing the axial proptosis, as well as the retinal hemorrhage. The retinal hemorrhage on the ipsilateral eye is likely to be due to pressure effect on the vascular system over there, particularly the venous drainage over there. So all in all, it points to a problem situated in the anterior cavernous that side with the facial swelling. The bilateral parotid now, whether the facial palsy bilateral is related to the bilateral parotid enlargement. If so, do we have to consider something like a Sjogren? And how does the cavernous sinus involvement fit in with that? These are the problems for which I think Kishore has posted this case. This is my analysis. Others can join in. Sir, anybody else, sir?
Yes, I'm Dr.
Patient
Chandra.
is non-toxic, sir. Patient is non-toxic. Bilateral facial palsy with ophthalmoplegia. In cavernous sinus thrombosis. Actually, it's a strong possibility, but the patient is so sort of consciousness normal and no evidence of other inflammation. It is bit very difficult to swallow the idea. Though the features anatomically it looks more of a cavernous sinus, but clinically he looks so normal.
It may not be cavernous sinus thrombosis. It may be a structural space occupation there. The structural, whatever it is like. I don't think it's
Structures in the cavernous sinus are affected.
it may not be a cavernous sinus thrombosis. Maybe a lesion
Bilateral chemosis, hemorrhage,
No, it is a
all in
unilateral
favor of
hemorrhage.
venous thrombosis.
Is it not a unilateral hemorrhage?
Bilateral hemorrhage,
Dr. Kishore, how is the left eye fundus and left eye third, fourth, sixth node?
left side is normal, sir.
Normal. So there is no bilateral ocular involvement. There is a right
that was a
bilateral
critical
ocular
error.
involvement.
When
Kishore,
sir,
one remote possibility is because the bilateral facial sarcoid, we'll have to consider sarcoidosis also.
I think that would
Yes.
be the first. I think
Maybe.
there should be a granulomatous lesion.
Yeah.
Behind
Sir,
the
you can see
sarcoid
the
or
parotid
also-
enlargement on both sides.
Yes, Justin, Vijayan, we are waiting. You can contribute. So also others, Lakshmi. Anybody is
Hello.
free to
Yes.
welcome to participate.
Sir, again, the granulomatous, as you mentioned, I told sir, the first possibility is sarcoid, which can explain all these findings of bilateral facial palsy, and he has showed parotid gland also a little bit enlarged, and the chemosis and other things, sir. That is the first possibility. Second possibility, as you mentioned, is possibility of tuberculosis. Commonly, we can have tuberculosis. Third is remote possibility IgG4, sir.
Sir, I would
There is
think
a
of
history of
Tolosa
Lassa
Hunt
weight.
syndrome.
I think there is a history of loss of weight. 8 kilograms he has lost 8.
Yes, sir. 6 kilograms. I was
I
about to
think
point
this
that.
all has to be taken into consideration.
Sir, Anand proposes Tolosa Hunt.
Maybe I think
Leukemia,
But,
lymphoma also should come into
Yeah. Yes,
Yes,
Vijay.
Vijayan. Yes.
Yes, please. Yes.
The weight loss. Kishore, anything else about on the weight loss?
Is there any associated
8
HIV,
kilos.
sir?
He said that there was a weight loss of 8 kilos in 6 months.
Sir, any HIV markers?
In
Sir,
Kishore, question is on HIV markers.
Sir, no, sir.
in general examination, was there any hepatosplenomegaly?
he said no. They asked him. He said no.
Dhanraj sir asked, it was no.
Hepatosplenomegaly, penis, lymph node swelling. He said no.
Inflammatory parotid lesion very rarely produces facial palsy.
Bilateral.
It's bilateral now. Parotid is bilaterally enlarged
Bilateral parotid enlargement, if it is
and
inflammatory,
bifacial weakness.
facial palsy is very rare. Very rare, unless otherwise parotid is sort of any infiltrative, it can produce facial palsy.
Presence
may
of
not be related
mumps,
to-
sir. Mumps.
Mumps will not produce facial palsy.
Mumps can produce bifacial weakness.
All rare. See,
Very
clinical
rare.
conditions.
Rare.
These are
Very
uncommon
clinical.
conditions.
Very. Or mumps
had
will,
a-
the classical teaching is mumps will not produce.
Will not. Correct. I don't think. I have a small suggestion. I can tell some interesting things in this patient. One, there is an extensive right, third, fourth, sixth, sparing the people. That is again very unusual, I think. It is a proptosis, pressure, there is a chemosis, everything. Still the people is spared. I think this is one interesting, unusual physical finding. And the second unusual finding is bilateral parotid, bilateral facial palsy. I feel that there is an infiltrative mass lesions behind his hand in the anterior cranial fossa involving third nerve, fourth nerve, sixth nerve, and very interestingly, it spares the fifth sensor. Doesn't pick up. So some findings are very interesting. Usually, such an extensive lesion, fifth sensor we expect to be involved here, not involved. And the second thing is,
Sir, VN sir, I would think of a non-Langerhans histiocytosis.
yes, we always, I think there is a infiltrative.
Don't think of pathological condition. Think of anatomical.
Yeah,
What about vision? What about vision? Vision was normal, completely normal.
vision is normal. That is very
Vision
interesting.
3/66 on right side.
Right eye was
normal.
right eye acuity was diminished.
Left side is normal.
The proptos
Right eye
eye
acuity
has
was
got
diminished, but
loss
there
of
were
vision.
retinal hemorrhages.
Working diagnosis could be an infiltrative mass lesions in the anterior cranial fossa extending to the middle cranial fossa, both sides. Probably presence of bilateral parotid involvement puts the first priority, can it be a sarcoid? The sarcoid will be. And next comes other lymphoma or infiltrative lesions here in view of the sarcoid.
Kishore, was
Sir.
the parotid region painful?
So parotid,
Was it painful or tender?
it's a non-tender.
At the ham gesture.
No painful also.
It was bilaterally enlarged, non-tender, and it was diffuse enlargement. Sir, as Dhanraj sir said, we were very surprised to notice that the pupils were normal in size and it was reacting to light. There was no dilatation of pupil. And all the facial sensory examination was meticulously, we did it, and it was normal.
So the parotids being non-tender, it goes more in favor of a chronic parotitis, probably of a inflammatory kind, because acute parotitis usually is a tender. So we can definitely sarcoid will be ranking number one differential diagnosis.
Sir, Dhanraj sir.
Yes, I have told. I put my diagnosis.
No. I'm just asking a question. Because of the parotid involvement, could we place the lymphoma and leukemia lower down?
No. See, it is a physical finding plus the entire one. There is a loss of weight. He is losing weight about 6 to 8 kg over a short period. We have to give importance to that. One, now, taking that history into consideration, with a mass-like lesions in the behind the anterior cranial fossa, behind the what we call the cavernous sinus site, that involvement, plus seventh now, the priority will be an infiltrative structural lesion in the right side. I think mainly behind the right cavernous sinus lesion, infiltrating the middle cranial fossa on both sides, producing facial palsy. Luckily, the left side is not affected here, I think. So the priority-wise, I think, if you take all the findings together, I think sarcoid may come as a first diagnosis, a clinical diagnosis based on this one. Second, invariably, a lymphoma or a leukemia or an infiltrative, any other lesion there, I think still we keep in your mind whether you been IgG4 related disease also. Keep it a possibility. I think it is still we keep it, I think.
Kishore, investigations, Kishore.
Yes, sir. So, as everyone had discussed, he has bifacial palsy. These are the possible differential diagnoses: Lyme's disease, sarcoidosis, Velkas and Rosenthal syndrome, infectious mononucleosis, vasculitis. But the presence of biparietal biparotid enlargement narrows the diagnosis to Heathford syndrome, sarcoidosis, Velkas Rosenthal syndrome, and infectious mononucleosis, mumps, parotitis, and parotid abscess and parotid bilateral glandular tumors. But in these conditions, ophthalmoplegia usually not reported. Ophthalmoplegia with biparotid enlargement and bifacial weakness has not been reported in these conditions. So now, unilateral ophthalmoplegia, 346 cranial now, it's a painful ophthalmoplegia. The possibility is cavernous sinus, orbital apex, or in the superior orbital fissure. Because to involve all the three nerves, this is the commonest three sites. How to differentiate between those sites? In cavernous sinus syndrome, usually you have oculosympathetic involvement, but it's not present in this patient. In orbital apex syndrome, second nerve is usually affected, but here it's normal. But in superior orbital fissure syndrome, there will be loss of facial sensation. That is very important because the nasociliary nerve passes between the two heads of the oculomotor nerve. So it will be lost early, and the corneal reflex also will be lost early in this superior orbital fissure syndrome. But in this patient, the corneal sensation is normal, and the sensation over the forehead is also normal, and there is no lacrimal hyposecretion. Most importantly, there is no dilatation of the pupil. There is no dilatation of pupil in this patient. We expect in a element third nerve palsy with the pressure pressure palsy, we expect a dilatation of pupil, but here pupil is spared, totally spared in this patient. This is the point against. So these are the common causes for superior orbital facial syndrome and differential diagnosis in cavernous sinus syndrome, Tolosahans syndrome, metastasis. But parotid and bifacial are not reported here in other conditions. So proptosis, again we expect there should be some lesion, some granulomatous lesion or some lesion to cause a diffused pressure to cause proptosis, and there should be some edema. So his routine investigations were within normal limits: hepatic, renal parameters, electrolytes, calcium, HIV screening, VDR, HbAs, everything was normal. ESR was normal, and CT brain normal. CT orbit showed axial proptosis on the right side, subcutaneous edema, diffuse thickening of all intraconal muscles. All the muscles of all the intraocular muscles are thickened. Optic nerve appeared normal, and left orbit was normal. And the impression was axial proptosis of the right side with diffuse thickening of all intraconal muscles. It's inflammatory thickening of the muscles. There is no lesion in the CT orbit. MRI brain and MRI orbit was also done. It showed subcutaneous edema on the right side of the orbit, diffuse thickening and enlargement of right medial rectus, right lateral rectus and right superior rectus muscle, and there was homogeneous contrast enhancement, and the surrounding tissue was inflammatory changes were seen in the entire orbit. Inferior oblique and inferior rectus appeared normal, and optic nerve appeared normal, and axial proptosis was seen on the right side. MRI brain was normal, MRA is normal, and MRV also normal. So this MRI finding rules out many structural changes, Tolosahans syndrome. According to current definition, unless otherwise you demonstrate a granulomatous lesion either in the cavernous sinus or in the superior orbital fossa, Tolosahans should not be diagnosed. Other metastases, malignancies, cavernous sinus thrombosis, carotid cavernous, everything ruled out, as there is no any structural lesion. Only the muscles are thickened and enlarged and inflamed. We expect a solid lesion or a granulation tissue or a space occupying lesion in MRI to cause a compression of the cranial nerves to produce the syndrome, but there is no compression at all. In MRI there is no space occupying lesion, only inflamed thickened muscles are noticed. This clinico-immunological imaging findings suggest orbital pseudo tumor. Orbital is a condition called orbital pseudo tumor. To confirm this, that nerves are not affected, a forced duction test was done on the right side, and it was positive, indicating a mechanical ophthalmoplegia rather than a cranial neuropathy. So the final picture is patient has got orbital pseudotumor, bilateral parotid enlargement, and bilateral element facial palsy. Are they linked together or are they different? If so, what is the link? A word about orbital pseudotumor. It's an immune mediated process.
Just a minute. Daniel, have you done a lumbar puncture?
Sir?
Have you done a lumbar puncture?
Lumbar puncture?
Did you do a lumbar puncture for the patient?
Sure, has a lumbar puncture and CSF analysis been done? Is what Professor Dhanraj wants to know.
Sir, no sir, lumbar puncture was not done, sir.
Any anti-GQ1B antibody test, Kishore?
Sir, just a minute. Sir?
I want to know whether anti-GQ1B antibody test was
done. Sir, just I am coming to that points.
Thank you.
So we planned for a biopsy.
One second, Kishore, did you rule out sarcoidosis? How did you rule out? X-ray chest was taken. How did you rule out sarcoid?
I am coming now, sir. The biopsy was done.
And what about X-ray chest? What about ACE? Calcium?
I'll be showing those results. You can see HIB, HBsAg, VDRL all are non-reactive. So we did a biopsy of the parotid gland. FNAC of the parotid was done. The smear showed normal salivary acinar cells with plenty of scattered lymphocytes and plasma cells against the background of proteinaceous material. There was no atypia or no granuloma. So it's more likely to be an inflammatory immune disorder. So we continue to evaluate on those lines. So ANA was done, anti-DS DNA was done, it was negative. And immunoglobulin IgA, IgG, IgM within normal limits. C-ANCA and P-ANCA was negative, serum ACA levels were within normal limits. CT thorax, there was no hilar lymphadenopathy, CT abdomen was normal, there was no nodes. All reasonable investigations for detecting immune-mediated disorders was done and it was found to be normal. So a literature search was done for orbital pseudotumor, parotid enlargement with lymphoplasmacytic infiltrates. And we came out with this article, IgG4 related disorders, wherein you have orbital inflammatory pseudotumor and multiple orbital involvement with multiple salivatory and lacrimatory gland involvement. We did IgG4 estimation, it was markedly elevated. It was more than twice the normal. Sir, any?
Your MRI contrast study did not show any enhancement of the meningeal enhancement.
In Sir?
Kishore,
Sir?
very interesting case, very well presented, and much more than that, very well discussed. Compliments and congratulations. Now go ahead and tell us how you treated the patient and what happened.
So we did a IgG4, it was positive. So IgG4, a short note on IgG4 related illness. It's a fibroinflammatory condition, can affect any organal system. Common presentation includes, sorry for that, the audio is not, I am using another mobile, that is why you have echo, sir. Common presentation include major salivary and lacrimal gland enlargement, orbital disease, autoimmune pancreatitis and retroperitoneal fibrosis and tubulointerstitial nephritis. The hallmark is that lymphoplasmacytic infiltrations with the predominance IgG4 positive plasma cells. Here in our patient, we did a biopsy in parotid. The lymphocytes were markedly, lymphocytes and plasmacytes were found in very sheets. The typical is the storiform pattern of cartwheel appearance of fibrosis. That is very typical, but usually it will not be present in salivary glands. That is, in other regions you can have this storiform pattern of pattern in other regions, but not in salivary glands. So criteria, this fulfills our criteria for diffuse or local swelling of single or multiple organs, IgG level more than 132 and demonstration of lymphoplasmacytic infiltrates. We can have condition IgG4 related neurological illness such as hypertrophic pachymeningitis with meningeal involvement causing cranial neuropathies, chronic headache, multiple cranial neuropathies, cavernous sinus or superior orbital fissure syndromes involving second, third, fourth, sixth nerves with retroorbital pain and altered vision and extraocular muscle palsy. In the middle cranial fossa, it can cause paralysis of cranial nerves from 7th to 12th. And in cervical, you can have radiculopathies. Any patient who has presented a subacute development of mass in an organ or there is diffuse enlargement, suspect IgG related condition. Can also affect other organ, non-neurological conditions. Patient was started on methylprednisolone, 500 milligrams for 5 days, IVBD for 5 days, and he showed dramatic improvement. There was a reduction in ophthalmoplegia, facial swelling, salivary and soft tissue swelling subsided, but facial weakness persisted. He was followed with oral prednisolone. Can see the improvement after. You can see the bifacial weakness still present and the facial edema, lid edema, everything subsided and his ocular movements was full. Look for take-home messages. Look for the non-neurological clinical presentations such as parotid enlargement. In a patient with total ophthalmoplegia with pupillary sparing, wake up, do a forced duction test. Meticulous examination for second cranial nerve or harness or fifth cranial nerve for localization in a patient with the presentation as cavernous sinus or orbital fissure syndrome. And many neurological conditions are identified with immune disorders such as IgG4 related disorder. They show dramatic improvement with steroids. Any tumor, subacute tumor-like conditions in anywhere in any organs, suspect IgG related disorder. It's a treatable condition. Demonstrate a storiform fibrosis. It's a pathological finding in IgG related disorder. The details can be obtained from up-to-date article. The article is available in up-to-date. Thank you.
Ishwar, I've got a doubt. Just because somebody has got a raised IgG4,
Sir?
just because that patient has got a raised IgG4 in serum,
Just a minute.
just because
Sir?
he has got raised IgG4 in the serum,
Okay, sir.
can we diagnose IgG4 related disorder? That's a big question. Because all the literature says that just because the elevated IgG4 may not directly show the pathology.
That's true, sir. But presence of lymphoplasmacytic infiltrates with the
No other inflammatory marker is raised here.
Yes, sir. ESR was normal.
I remember a study shows that even in a general population, several people may have raised IgG4.
Correct. See, I think I had one patient with IgG4 ophthalmopathy. We presented in the Bilaspur conference, I think. There is no systemic evidence of any infection. ESR was normal, everything was normal. Only based on the radiology report and raised IgG4 to a significant level. I think there is a level. Above a specific level, if it is raised, I think it is abnormal. I think we can't point. A biopsy would have been an idea. Maybe if you have done an extraocular muscle biopsy, it must have given, I think. Maybe you may not have the facilities to do that, I think. And the next option is, I think, a therapeutic response to steroid. I think there is an excellent response, I think, to steroid. I think. But, no other differential diagnosis, I think. Hardly any other one. But it is quite interesting. The physical findings are very interesting. Shall we proceed? Shall we proceed with this case or
Yes,
next
sir.
case?
Yes, sir. Yes, sir. Thank you, Kishore. Thank
Thank
you
you.
very much.
We congratulate him. He has done well, I think, maximum possible. Very good. Shall we go to the next case?
Please, sir. Please.
I think next case is going to be presented by
Rajarajan.
Dr. Rajarajan from Kaveri Hospital, neurologist.
Sir, you can introduce him, sir.
See, I do not know much about you. All that I heard it from you, that he is a neurologist, studied from Madras Medical College. I think about 5 years or 6 years back he has passed. I think he's supposed to be one of the brilliant students. Very clever, very clinician, very intelligent clinician. At present, I think he's working in Kaveri Hospital, Trichy. I don't know much about him, I think. I request you kindly to present.
I am not able to project the screen, sir. My screen.
Ruben, can you help him, Ruben?
Hello, sir.
I think Dr. Kishore has not stopped sharing. Kishore has to stop sharing.
Yes, sir.
Only Rajarajan can share.
Sir, Kishore, sir. Sir, now try one more time, sir.
Be able to see, sir? No, I'm not able to project.
Mr. Anil? Mr. Anil, you can help.
Yes, sir.
Hello.
Yeah, I'm not
Yeah.
able to project my screen, sir.
Yeah.
One.
Yes, sir. Hello.
Hello, I'm not able to project my screen, sir.
Yes, sir. Can you see on the bottom there is this option share screen?
Yeah.
Just click on that.
Okay.
After that, you can select first option screen.
Well, it has two options. Who can share? Only host.
Yes, sir. Now you can try.
Share screen and are you able to see my screen, sir?
No, sir. We can't.
Illa, under
You need to share screen. You need to be share on the Zoom, sir.
Wait.
Yes,
Ah,
now
yeah,
we can see.
Yes, sir. Yes, sir.
Okay.
Now it's coming, sir.
Okay. Good afternoon, everyone. Can you able to hear, sir?
Yes, please.
Okay.
Yes, sir. Audible, sir.
Good afternoon, everyone. I am Dr. Rajarajan from Kaveri Hospital, Trichy. So I'll be presenting a case of unstudied gentleman. So before going to presentation, I would like to thank Dr. VN sir and Dr. AV sir from Trichy for giving me this opportunity. So
AVS refers to AV Subramaniam, a
AV
leading
Subramaniam sir
neurologist
from
at Trichy.
Trichy, sir. So this 79 years old gentleman was recently hospitalized and treated for COVID-19 pneumonia. has presented with the chief complaints of unsteadiness while walking for the past 2 weeks. So he was apparently normal till April 2021. In May 2021, he was hospitalized for fever, generalized weakness, and worsening dyspnea 7 days duration. Nasopharyngeal swab test and the CT chest done at that time was positive for COVID-19 pneumonia with elevated inflammatory markers. Hospitalization was uneventful. He was discharged after 10 days of treatment, following which he continued to have debility, loss of appetite, and decreased food intake. So after discharge, he was isolated in a room in his house by his family members, and he received just a minute. Okay.
Rajarajan, you are not audible.
Not audible.
So now, sir, am I audible now?
now, yes.
Okay. So after discharge, he was isolated in a room in his house by his family members who feared that COVID would spread to the other unaffected family members. So during this home isolation period, he received only basic and minimal care from relatives due to COVID restrictions and fear of COVID. But he was able to do all activities of daily living and ambulate independently. In July 2021, he complained of balance issues such as feeling unstable when standing, unsupported, and feeling unsteady and swaying while walking. There was a tendency to reel and fall in an unpredictable direction. No history of difficulty in handling objects, and he was able to bring food to his mouth normally. His wife noticed that he was walking much slower than usual, but she denied any history of tremors. He took much longer than usual to make everyday movements such as lifting the arms or legs. She reported no falls, but disclosed that he has had some close calls when getting out of bed. There was no associated vertigo, loss of consciousness, ear pain, hearing loss, tinnitus, or headache. He slowly became more dependent on his wife for his daily tasks such as shower, dressing, etc. No history of clumsiness of hands, no history suggestive of proximal or distal weakness, no history of thinning of limbs, twitching of muscles, no history of sensory disturbances, and no history of bowel and bladder disturbances. So he complained of slurred speech, which was slowly progressive for the past 1 month in the form of poor pronunciation of words, mumbling of words. There was a change in the speed and rhythm during talking, but he was able to convey the messages to some extent to his relatives. He had no difficulty transferring food through the mouth, but had some occasional episodes of coughing while drinking liquids. No history of repetitive swallowing, retrosternal hanging up sensation, regurgitation of undigested food, halitosis, and no history of nasal regurgitation. He was admitted with the above complaints on July 23rd, 2021. On day 3 of hospitalization, he developed a few episodes of confusion with irrelevant and abnormal behavior in the form of getting out of his bed and walking around the room for no reason, tendency of putting bedsheet in his mouth, difficulty in recollecting. He also had difficulty in recollecting specific events, for example, the previous COVID admission in our hospital, and difficulty in remembering names of the family members. He also had short emotional outbursts lasting only for a few minutes, and there was in the form of abnormal and inappropriate crying. So on day 4 of admission, during morning rounds, he was noticed by the consultant to have a sudden jerky movement involving his upper trunk, precipitated by sudden creaking sound of the opening door. Since then, he was noticed to have similar movements precipitated by sudden loud noise. He mentioned seeing image of a person in the walls with smaller flashing squares inside it. He also had difficulty in falling asleep, hard to stay asleep, and he woke up too early and not able to get back to sleep. He also felt tired when he woke up. So on day 5 of admission, he developed a generalized tonic-clonic seizures. Since then, his sensorium gradually declined and he became drowsy with minimal response. So past history, there was no history of stroke or stroke-like events, seizures, involuntary movements, no history of measles in childhood, no history of fever, headache, nausea, vomiting in the past, no history of GI symptoms, weight loss, no history of fever, myalgia, joint pain, or rashes, no history of hypertension, diabetes, or thyroid disorders, and no history of ethanol intake. Family history was unremarkable, and specifically no history of similar illness in his family members, no history of psychiatric disease or suicides. So in a post-COVID status patient, subacute onset of symptoms and gradually progressive, adding symptoms one by one. We have seizures, we have some gait ataxia, dysphagia, dysarthria, and some behavioral abnormalities. So where is the lesion? Gait ataxia, whether it's a sensory, vestibular, or cerebellar, there was no sensory disturbance and there are no vestibular symptoms. So gait ataxia would be consistent with the disease of cerebellum, particularly cerebellar hemisphere.
1 minute.
Yes, sir.
What is the total duration of the illness? Total duration.
Total duration is 1 month, sir.
1 month duration. Okay. Chat. Okay. Chat.
So with the presence of gait ataxia and speech disturbance, the gait ataxia would be consistent with the disease of cerebellum, particularly cerebellar hemisphere. So I would like to group some of the symptoms. Like
gait ataxia, you like to put the lesion cerebellar hemisphere?
Yes, sir.
Will he not?
Rajarajan.
Yes.
Cerebellum?
We are only in the stage of history.
Yes, okay.
So can we have a discussion at this point of time?
Yes, sir.
Can you try to, I think somebody can analyze from the history. I think one of the men can get
Yes,
the
sir.
history. And
Yes, sir. As usual, I shall start. As Rajarajan has pointed out, he has a fairly diffuse involvement of the brain. We can narrow it down all to the brainstem, or we can consider it as a diffuse involvement. Predominantly, the features at present includes confusion, irrelevant and abnormal behavior, some myoclonic jerks, sleep dysfunction, all of which points out to a diencephalic involvement involving the medial temporal as well as the probably with the seizures also pointing that to that area of involvement. Ataxia may probably suggest an extension into the brainstem, or possibly I would even call this as an encephalopathic state, because he has some close calls on falling and ataxia, which we do not as yet know, which we have seen with the post-infective illnesses. So this followed a COVID-19 infection. But the point is, this is progressive, and he has observed the progression when admitted with him. So all in all, it points to a diffuse involvement of the brain, possibly principally involving the diencephalic region, which can, and the hypothalamus included, which could explain most of his symptoms described. And I would probably suggest that the ataxia or the difficulty in walking due to a basal ganglionic involvement rather than going to the cerebellum. And my first possibility would be autoimmune problem, which is happening on the background of COVID, not directly related to COVID-19 infection, but possibly an autoimmune related triggered off maybe by COVID or independently happening. So I would put it as an autoimmune encephalitis or autoimmune encephalopathy at this stage, principally involving the diencephalic basal ganglia and probably the lower brainstem. This would be my interpretation of what he has presented. Sir, anybody else, sir?
Sir, possibility of Adam, sir. Kannan. Okay, Kannan, sir. Possibility of Adam.
Kannan?
Adam, sir. Yes, sir.
Sir, Kannan is suggesting the possibility of an Adam.
Adam means
acute
disseminated encephalomyelopathy.
Encephalitis, demyelinating, ADM.
Sir. Hello.
Yes, Justin.
Yes, sir. As you mentioned, sir, this is a diffuse encephalopathic process involving the all lobes and the basal ganglion and structures and the brainstem structures, as evidenced by dysphagia, dysarthria, and other things. In the background of COVID and the viral infection has precipitated all these things. Possibilities, first possibility, as you mentioned, is possibility of autoimmune encephalitis. And the myoclonic jerks and other things, can it be a possibility of associated, a possibility of CJD in this age group, older age group? That may be the second possibility I'd like to think of.
Yes, Justin, but ultra short.
Yes, sir.
I have one small doubt. When was the COVID? Is it 2021 or 2020?
2021 May, sir.
May 2020.
May he had COVID and following this short period. So,
and he has got a sleep disturbances, doctor. Sir?
Yes, sir.
Yes, sir. Yes, sir. Hypothalamic involvement.
Other possibility is IG lung, sir. FI.
Okay. Yeah. Or basically coming to autoimmune encephalitis.
Yes, sir. Yes, sir. Everything comes under autoimmune.
Why not it be a paraneoplastic? It's a short duration. It is a, can it
Yes,
be?
Vijay.
Huh?
Hello.
Just
Yes,
testing.
Sir, it's post-COVID. I think we should think of post-COVID encephalopathy also. We've had a few cases.
But is it
Simply
progressive, ma?
post-COVID encephalopathy.
Vijay, is it progressive like this?
So post-COVID
I've also seen
encephalopathy, we had a
post-COVID
few cases
encephalopathy. Pardon?
which were initially worsening, subacute onset, progressive, and then they responded to immunoglobulin and steroids. I mean, CSF should include a COVID antibody also. That's a suggestion, that's all. Anyway, it's a diffuse process. Encephalopathy, of course, everything will come into the differential diagnosis. Since it's specifically post-COVID, so post-COVID encephalopathy also.
COVID,
Again,
COVID was
autoimmune.
Vijay, COVID was in May. The
Sir?
problem started in July. The COVID infection was in May. The
Yes, sir, we've
neurological
seen post-COVID like this, sir, after 2 months,
correct.
1
I'm
month, 2
coming
months.
there. The neurological symptoms started in July and is progressing.
Sir.
Progressing over 6 to 8 weeks. So that
Yes,
is
sir,
where
yes,
we
sir.
need to consider post-COVID, whether it could still be a long COVID.
Yes, sir, long COVID, and we've had one or two cases like that recently. That's why. Nothing we were able to pick up except that CSF COVID antibody was grossly elevated, indicating intrathecal synthesis. That's all. Thank you.
Any visual involvement, Rajarajan?
No, sir. Apart from visual hallucinations, no other visual symptoms.
Earlier, initially, he did not have any visual.
No, sir. No, sir.
Jain.
Thank you.
Vijay.
Sir, Dhanraj, sir. Can you
I'm not
proceed
sure.
or any more discussion, sir?
I'm not sure. I have not handled any COVID cases, I think, neither this one. But I think what is more interesting is it's about 2 months after getting the COVID infection, he has developed this problem. There are some issues. I think the man has not been well cared by the family. He had been isolated. I'm doubtful whether he has been fed by the family adequately. There is some area he had been isolated from the family, not taken care well by them. Subsequently, I think he has developed the main issues, ataxia. And then you have, I think, the speech problem, confusion, convulsions, higher function. Of course, it is very easy to tell that it could be secondary to one of the autoimmune or delayed para-infectious COVID-related diffuse encephalitis. Maybe it is one. I think we should also keep in mind any other possibilities, but I am not able to sure what exactly is the cause that could be.
Rajarajan.
Yes, sir.
Rapidly progressive encephalopathy, autoimmune principally, we can't exclude what Justin said, rapidly progressive CJD.
Okay, sir. So we have actually 3 distinct clinical syndrome. One is dementia, rapidly progressive dementia, ataxia, and cortical symptoms. The tempo of dementia and ataxia is subacute. So what single disease could cause all 3 of these syndromes? So what is the lesion? Is it a cerebral or cognitive affective syndrome? So usually limbic cerebellum is represented by vermis and vestigial nucleus, whereas cognitive cerebellum usually in the posterior cerebellum. So apart from motor coordination, it also plays a role in cognition and emotional regulation. It is usually characterized by executive dysfunction, visuospatial disorganization, and emotional dysregulation and language deficits. But this is a true amnestic deficit with a memory disturbance, which was seen in this patient. It's not a part of CCAS syndrome. And this patient began to have uncontrollable jerks that were consistent with the myoclonus. So this total myoclonus indicates that extracerebellar structures are becoming involved. So this is less unlikely. Is it a disease starting in the cerebellum and spreading into extracerebellar structures? Ataxia plus syndrome, which has toxic metabolic infection, leptomeningeal carcinomatosis, immune-mediated, and neurodegeneration. Both prion as well as non-prion related neurodegeneration. So first, initially at the presentation, he had this ataxia, dysphagia, and dysarthria. We initially thought of some metabolic process going on. So So we thought of initially the vitamin B12 can present with subacute.
Rajarajan,
Yes, sir.
Rajarajan,
Yes, sir.
Rajarajan,
Yes, sir.
have you described the clinical findings?
Which one, sir?
No, have you mentioned describe the clinical? We were discussing only on the history. We have not discussed the clinical findings.
Okay, you want the clinical findings, sir?
Obviously,
See,
of course, yes.
discussion should be based on the history. Then you can come to the physical findings.
Okay, sir.
Any investigation?
So on general examination, the patient, the vitals were stable and there was no postural hypotension. And he was thin built and moderately nourished. There were no fungal lesions in the oral cavity, nasal cavity, and the palate. In CNS examination, GCS was 15/15. Speech, it was of slow rate, strained voice quality, and monotonous. He was apathetic and amotivational. There was psychomotor retardation, impaired episodic, semantic, and working memory. There were digit span backward test, troop test, and trail making test were impaired, and there was motor perseveration. So cranial nerve examination, the only positive findings is jaw jerk was exaggerated and gag reflex was impaired with pooling of secretions. Motor examination, there was rigidity and all deep pendant reflexes were brisk. So, and we have cerebellar signs, no meningeal signs, and we have extrapyramidal signs like bradykinesia, rigidity, and postural instability, but there was no resting tremors. So, at the end of clinical findings, we have UMN signs like pseudobulbar palsy. Jaw jerk was exaggerated, which localizes bilateral disease above the level of pons, and brisk deep pendant reflexes. Extrapyramidal signs like bradykinesia, rigidity, and apathy, amotivational, and executive functions. Motor perseveration localizes to frontal lobe. Memory, behavioral disturbances localizes to the temporal lobe. Impaired gag reflex, medulla may be involved, and cerebellar signs.
Can you elucidate the cerebellar signs? Expand on it, please. You said minimal incoordination.
Okay, this diatokinesia was present, sir. Only were mild incoordination, bilateral upper and lower limb was present. There was horizontal nystagmus, intentional tremor was present, and tandem gait was not possible.
But what about regular gait?
Regular gait was possible, sir. Regular gait was possible.
Did you find anything abnormal in his gait?
No, sir, no. There was no wide stance gait or something like that.
It was not an
Finger
extrapyramidal gait
myoclonus.
also.
Any jerk, finger myoclonus?
No, sir, no finger myoclonus. Only the patient experienced myoclonus to sudden loud noise, sir.
Startle. That's a startle response.
Startle response.
But did he have an extrapyramidal gait?
It's more of extrapyramidal gait, sir.
Any videos on it? You have any video?
No, sir, I don't have any videos.
Okay, thank you. You continue. Is there any more physical findings to be mentioned?
No, sir, no. That's all, sir.
Okay, I think the discussion would be along the same pattern as earlier. Only thing you started off saying, principally focusing on the cerebellum. That's why I wanted you to highlight the findings. See, after going through the clinical findings, principal involvement doesn't seem to be in the cerebellum. So you were talking about cerebellar.
But initially the patient experienced had cerebellar signs, sir, but later on the symptoms are added up.
No, the history was suggestive of an ataxia. That's what you said.
Yes,
but
sir.
On examination, we don't find that much at all. So we cannot focus cerebellum plus syndrome.
Okay,
it has to be something plus cerebellum or brainstem. All your findings which you have mentioned here for the cerebellum could go with the brainstem itself. There's no need to invoke the cerebellum at all. It could be brainstem functions itself can explain this abnormality. Okay. So still we come back to the same situation as earlier. Predominant possibly a diffuse cortical, or it might be principally the diencephalic, medial temporal, hypothalamic, and the brainstem involvement, explaining all the features you see as including the basal ganglia. And first possibility, of course, will be a autoimmune encephalitic problem. And as we can't exclude a CJD, which is too rapid, I would say too rapid. But you say cognition as he has a significant cognitive involvement also, suggesting a cortical involvement. Yes. So yes, we have these two possibilities.
And malignancy and paraneoplastic is also possible.
That would be my thinking. Of course, others can contribute, please.
Sir,
Yes,
Sir,
Justin.
yes, sir. As mentioned, because being an older age group, correctable causes like any as vitamin deficiency, electrolyte imbalances, and toxins, and hyperthyroidism, auto Hashimoto's, our routine. Whenever you see a myoclonic, we have to rule out certain things. No? That are all come into place. Being an older age, considering before branding as an autoimmune bar. Rapidly progressive CJD, sir.
Justin, it's a Startle
Yes, sir.
syndrome. More than a myoclonus, it's a Startle syndrome.
Yes, sir. Startle syndrome. Yes, sir. That is more. You can have in a drug-induced startle. We don't know what drugs he was on, or the hyperthyroid state also produces and hypoxic episode, which was we don't know whether the COVID has developed an hypoxic insult to the brain, or the patient developed any hypoxia during that COVID admission, and all these things will come into play whether he has developed an anoxic episode and other things, sir.
Yes, sir.
Sir, still it may be a post-COVID syndrome, sir.
Yes.
Post-COVID.
Yeah, that is what Vijayan said. Yes, Kannan.
Yes, sir. Yes,
Thank
sir.
you.
Yes, sir.
Dr. Dhanraj speaking.
Yes, sir.
There is, in addition to this post-COVID syndrome, see the entire part, actually it is the cerebellum was thought first. Subsequently, the physical finding do not favor a cerebellum. On the other hand, extrapyramidal signs are more. Higher cognitive functions are more. Seizures are there, I think. Elderly person here, I think. Can it be a paraneoplastic? In addition to the autoimmune, can it be a presentation of paraneoplastic syndrome developing over a period of 2 months?
So paraneoplastic, autoimmune, or you are talking of something else?
Next would be a paraneoplastic. I don't know about this autoimmune. This 79 years old, I have not had a chance to had a senior patient like this.
No, sir. The question is paraneoplastic, autoimmune encephalopathy.
Paraneoplastic. One possibility. Probably COVID-19 plus post-infectious diffuse encephalomyelitis may be a possibility. Next, I think it is a paraneoplasty has to be considered, sir.
Rajarajan, what did you
sir.
think and how did you proceed?
So initially, we thought of immune-mediated paraneoplastic malignancy and with neurodegeneration, prion as well as non-prion diseases. So these are all the investigations.
Rajarajan,
yes, sir.
If you think of paraneoplastic,
yes, sir.
with this sort of a presentation, what paraneoplastic would you think of? Which antibody associated?
So usually in the Zika4 antibody associated paraneoplastics were associated with some kind of cerebellar involvement and some subacute cognitive decline.
Cerebellar illaya. Niya cerebellum nu sollittu irukka.
Presentation
Cerebellum is
presented as a cerebellum. Cerebellar findings are hidden now.
Sir, may I come in, sir, or may I come
Please,
in for
sir,
a second?
Please, yes, please do.
Sir, there are two different phases of the case, sir. One, when he came to the OPD, when he presented to the OPD, he had only unsteadiness of gait, which was primarily a disequilibrium, looking like a brainstem plus or minus cerebellum. It is only later that the other symptoms got added, the other signs got added within a period of 2 weeks. So the initial presentation was just a gait ataxia. And as Professor Dhanraj said, there were a few issues we had in mind. One, as he said very rightly, the patient was isolated after COVID and the relatives admitted that they were afraid to go into that room. Professor Dhanraj correctly guessed that he was not fed properly during those
AVS, AVS, can you just wait for a minute?
Yes, sir, yes.
Ruben or Shanmugani, can you switch off the mics of others? There is a constant disturbance going on.
Hello, sir. Okay, sir.
Yeah.
Please,
Take
we
care,
are
sir.
not able to hear Professor AVS. AVS talking.
Okay, sir. Okay, sir.
We'll take care, sir.
AVS, continue.
Okay, sir. Sir, in the initial part of the presentation, the OPD, he had only
we
one
heard it.
complaint, which was unsteadiness of gait. and there were no other signs. It was primarily a disequilibrium, not to any particular direction. And all the other symptoms and signs got added up in the next 2 weeks when he was in the hospital. So initially it was looking like a gait ataxia in an elderly person. There was a history of a poor nutrition because of COVID-related restrictions and isolation. So definitely in the very initial part of the presentation, a nutritional cause was thought of. Definitely that was one of the things which was in our mind. Professor Dhanraj correctly guessed it. Second thing was because of the age, we were thinking of a paraneoplastic cerebellar degeneration. That was one. And the third one was a degenerative disease. The fourth one, as he said, could be a prion. So these were the four possibilities which we were thinking in the initial part of the presentation in OPD. But while he was hospitalized, then we noted that, new signs got added up every day. Every day we started seeing new signs. And then the outlook kept on changing. The differential diagnosis also kept on changing. So that was the small background which I wanted to add.
For clarification, this patient was first seen by A.V. Subramaniam, and then for workup went on to Kaveri Hospital where Rajarajan worked up the case. So the primary presentation is known to A.V. Subramaniam.
Go ahead, sir. Dr. Rajarajan, please go
Yes,
ahead.
sir. So on the basic investigations, only we get some elevated inflammatory markers. ESR was elevated, CRP and LDH was elevated, and D-dimer was significantly elevated.
Can you compare these values with the COVID values? Is it decreasing?
No, sir,
It's
actually increasing, sir. It's actually increasing.
So
previously
to the time when he had the COVID.
What's that?
To the time these values were there when he had a COVID infection in May 17.
So
May
at the
21.
time of discharge, D-dimer values are around 800, sir.
Which one?
D-dimers.
Okay. What about CRP, LDH?
I think CRP, both CRP and ESR were normalized at the time of discharge.
Okay. So this is a subsequent elevation.
Subsequent elevation.
Okay.
So, and we did serum B12 was normal, folic acid and metabolic parameters were normal. CSF analysis was normal. And all metabolic parameters were normal. Thyroid was normal. Anti-TPO, anti-thyroglobulin was normal. And we have paraneoplastic panel antibodies here. Zika-4 antibody was positive, but the Zika-4 antibody is usually associated with the small cell lung carcinoma with cerebellar degeneration, but the CT chest and abdomen was negative for any mass lesions. And the connective tissue workup was negative. Autoimmune encephalitis panel was negative. And we did a neuron-specific enolase, which was mildly elevated. We did a whole genome sequencing looking for any PRNP gene mutation, which was negative. And the EEG showed a periodic sharp wave complexes. And this is the MRI finding, which shows a high hyperintensity in the caudate and basal ganglia region, and there are some cortical hyperintensities. So this caudate hyperintensity is actually, there is a mild diffusion restriction is present. In CJD, usually the perirolandic area is usually spared in CJD, but in our case also the perirolandic area, there was no any hyperintensities. So these are some of the, on the right side, you have some of the cortical patterns of MRI in different patients, which show both cortical and subcortical involvement. On the left side is our patient. There is mild cerebellar atrophy and basal ganglia hyperintensity as well as cortical hyperintensities. So these are some of the usual findings which we see in CJD. It's there can be focal, diffuse, symmetric or asymmetric involvement of cerebral cortex, basal ganglia, in particular corpus striatum or both basal ganglia and cerebral cortex. Perirolandic area is usually spared in CJD and you can have cerebellar atrophy. The final diagnosis, it's a case of possible sporadic CJD. So prion disease, it's a neurodegenerative disease. It has long incubation periods and progress inexorably to death once clinical symptoms appear. There are three categories: sporadic, genetic, and acquired.
Sir,
Sporadic
excuse me.
Yes, sir.
What was the outcome?
The patient expired just 2 months back, 2 weeks back, sir.
I would still strongly believe that you should have done a COVID antibody in the CSF.
COVID antibody in the CSF was negative, sir.
Did you try any immune modulator therapies?
We just tried steroids alone, sir.
Vijayan,
Sir,
is not the MRI clinching for CJD? It almost clinches the diagnosis.
I think we are learning about COVID also, sir. Still yet to learn. So MRI can be normal in COVID, and basal ganglia hyperintensities along with brainstem hyperintensities have been described in COVID also.
Yeah, but the ribboning pattern of cortical involvement is very
just thinking of a treatable diagnosis, sir, that's all. Because we had a similar case where MRI was normal, COVID antibody was positive, gave immunoglobulin, and he's doing remarkably well. That's all. Just add a treatable condition to that, that's all.
Yes, sir. Yes, sir. Rajarajan, continue.
Yes, so sporadic CJD is more common and accounts for more than 90% of sporadic prion disease. Center for Disease Control and Prevention outlined 2 criteria for probable sporadic CJD. Definitive diagnosis requires neuropathological confirmation, and this is the criteria for probable CJD. Either you should have neuropsychiatric disorder with a positive real-time quaking induction conversion test, or rapidly progressive dementia with at least 2 of the following 4 clinical features. In our patient, we had myoclonus, cerebellar disturbances, pyramidal as well as extrapyramidal dysfunction. And supportive findings on 1 or more of the following tests. The EEG showed a typical periodic short wave complexes, and MRI showed hyperintensity in the caudate, putamen, and at least 2 cortical regions like parietal and frontal. And routine investigations should not suggest an alternative diagnosis. So there is a rapidly progressive mental deterioration, often with the behavioral abnormalities, and myoclonus are 2 cardinal clinical manifestations of sporadic CJD. Extrapyramidal signs such as hypokinesia and cerebellar manifestations are also common. Features atypical for CJD are cranial nerve abnormalities, peripheral nervous system involvement, disturbances of pupillary response and trigeminal neuropathy, vestibulocochlear dysfunction. Sensory signs and symptoms are common clinical presentation in variant CJD but not in sporadic CJD. So these are some of the clinical features which differentiate variant CJD and classic CJD. Variant CJD, the median age at onset is much younger, it's around 29 years, whereas classic CJD is around 65 years. And median duration of illness in variant CJD is around 13 to 14 months, and in classic CJD is around 4 to 6 months. And clinical signs and symptoms in variant CJD, you have early prominent psychiatric disturbances, whereas in classic CJD, they present with the dementia and early neurological signs. And periodic short wave complex are often absent in variant CJD, but often present in classic CJD. With regard to neuropathology, there is loss of neurons, gliosis, and spongiform degeneration. While neuropathology provides a definitive diagnosis, a brain biopsy is not always required in most patients. Autopsies are important to definitely diagnose and determine its type. It is important mainly for surveillance reasons to monitor the possibility of acute cases and possible emerging prion disease. Example, the potential transmission of chronic wasting disease from deer to humans. So this is a high power micrograph of classic CJD demonstrating the typical size variation of CJD vacuoles. And I just noticed an important paper regarding CJD in a patient with COVID-19. So is it COVID-19 accelerating the neurodegeneration? We don't know the answer. Thank you.
Thank you. Anybody want to have a small comment on?
Kannan, you want to say something?
Sir, yes, sir. Now I had an article. There is a presentation like a CJD with in a COVID-19 patient. Now only I posted this article, the abstract, sir. So it says there is a evidence. There is a CJD presentation may also can occur in COVID-19, but still I have the possibility of post-COVID syndrome. A course of IVIG can be tried, may be tried in this case. Outcome may be.
This is the same article which Rajarajan posted just now, showed us just now. So raising the question of whether COVID would have accelerated the course of the CJD, so that making it rapid progression. Rajarajan, you did try IVIG also, no?
No, sir, we didn't try IVIG, sir, because the patient went against medical advice.
Professor Dhanraj had something to say. Professor
No, I
Dhanraj,
have
sir.
nothing much to add. I think putting both together the MRI finding, the fast evolution plus the EEG finding, I think there is no differential diagnosis, I think. But we'd like to ask Dr. Kannan whether his patient had this similar MRI finding, similar EEG pattern.
Sir, Kannan did not have a case, sir. Kannan is just posted the literature.
I see. But this picture, I think the MRI, EEG finding, clinical profile, I think favors a CGD only, a classical CGD. The evolution is little fast. That's
Faster. Rajaran.
Justin, you have your Justin.
Yes, sir. Yes, sir. Sir, is there history of taking this animal meat, sir?
No, sir. No history of
variants,
anything.
CGD.
Because the hunters know, usually the old people will go for, previously they will go for hunting and they take the raw meat from the animal.
If I am right, I think he's a vegetarian, Justin.
That's what I'm asking. Sometimes I have seen in a vegetarian also, sir, some vegetarian.
Justin,
Yes, sir.
he called him as a gentleman initially.
Yes, sir.
But he's a gentleman, but the disease was not a gentle disease.
Yes, sir. Yes, yes.
It
Well
was
said,
not,
sir.
Only thing that I would like to add, sir, that we've seen CJD following this so-called chelation therapy for CAB, I mean, coronary artery disease. I had 2 patients who had undergone chelation therapy here for coronary artery disease, and then they developed CJD. And
What
regarding that
chelation,
question,
Vijayan? Chelation
sir,
with
they
what?
undergo this chelation therapy, sir, and what is that? External enhanced counterpulsation.
Sir, what is the agent used?
Ozone therapy along with chelation, desferrioxamine and all. So I'm not exactly sure about what they do there, but they undergo this every monthly, and I've seen this 2 patients like that develop CJD. Typically with the, and regarding the question of Professor Dhanraj, no, our patient does not have had a normal MRI, and the EEG showed only diffuse slowing. Did not show classical complex.
I think you should report it. You should report it so that everybody is aware of it.
Can I add one more point, sir? Because
please,
we have started seeing more and more, at least hearing more and more about the CJD after this COVID. And is it like mucormycosis after COVID? Are we getting more and more cases like that? I still do not know. I may be very, because it can also be transmitted through injections. Or the patients, more and more patients are getting admitted, and the same patient treated with early symptoms of CJD is being treated with the same injection or injection transmitted or anything like that, or are we getting more and more? Should we have to be aware of it also in treating COVID?
Meghandan, sir.
Yes, sir.
Can you tell us more about, you are saying that you are hearing more and more reports of CJD post-COVID. What is it, sir? Because I have not come across that. So can you
in the sense
tell us
that
more about that, sir?
I'm seeing it more in the literature, sir. When I go through the literature, there are cases getting reported as post-COVID syndrome as CJD features, or CJD syndrome where it is all the features are positive. I have had some 2 to 3 anecdotes probably where I have come across. At least the term CJD is being discussed more and more.
Okay.
I still do not know. But I am little worried because it is a transmissible disease. And
Yes,
the person who is treated there, the whole area should be isolated. The whole area, once he has been diagnosed there, or it is confirmed there, we have to be a little more careful. That's what I am worried.
Yeah, what we should consider is whether it is a CJD proper or is a CJD-like encephalopathy following COVID, as Vijayan has been stating, pressing on it. CJD-like presentation of a COVID encephalopathy.
The EEG and MRI, they show typical features.
No, in your cases, which you mentioned, the literature being mentioned, that they are referring to more CJD. Is it CJD-like presentations or is it CJD itself?
I don't remember
just want to know from you.
Yeah, I will definitely go through it and I inform you, sir, later, because I am hearing more and more. That's
Yes,
what
sir.
I think I'm seeing more and more.
Yes, sir. Yes, sir. Thank you.
We did a brain biopsy.
No, sir, we didn't do.
No, you projected a slide, no?
Yeah, that one from the literature, sir.
Literature, sir.
Oh, okay.
Anybody has got any comment?
We are learning more and more.
Only
sir.
one
Dhanraj
comment,
sir.
sir.
We are learning
Before,
more and more.
only one comment, sir. Before closing it, just CJD with all our EEG, MRI, clinical findings, still we can only make a diagnosis of possible CJD.
Yes.
Without I don't think we can make a diagnosis of definitive CJD. So, of course, everything else has to be considered before dumping it as a CJD. That's all. Nothing else, including autoimmune.
Rajarajan,
Yes, sir.
RT Quaker conversion is not done in India, is it?
No, sir, not done in India, sir.
But 1333?
1433, I checked in Bangalore, sir. It was not done in
Nimmans,
Bangalore.
yes.
Only in Nimmans they are doing it, sir.
Nimmans
Again-
are not doing, sir. Not doing, sir.
1433 again is not definitive. Again, it's not definitive.
No, with the features
No.
only you will have to tie it
Yes,
up
sir.
with the
Correlate.
features.
Yeah. Yes, sir. Yes, sir.
Okay.
So recently, 2 lab workers who were testing for CJD developed CJD and died abroad. After that, many of the centers which were previously testing for CJD have stopped testing. So now we are unable to do 1433 anywhere. This is
Yes,
after
sir, yes, sir, agreed.
this is after the scare. 2 people
True.
died.
True.
Most of the labs have stopped the testing.
Okay.
So we would have to go by the biopsy then,
Yeah, that's right.
and the clinical and the other radiological correlates.
Now, biopsy is not done, sir. Biopsy, if you say that the biopsy for CJD, nobody will be ready to do it.
Nobody will do it.
Yeah.
That also is there. Okay. So what shall we do?
That's it, sir. Your
Conclude.
concluding remarks and we
Conclude
close,
as-
sir.
Yes, sir. Good. I think it is a very good presentation. Very nice. Both the cases are very much interesting, challenging as a clinical material, I think. Both the presentators, I think we should congratulate. Thank you.
Yes,
I
sir.
think Veer Natarajan, you want to tell final word? Please tell.
Nothing, sir. As I said, we learn more and more as we hear more.
Definitely,
and more.
no doubt. We learn more.
And,
No
and we
doubt.
thank the presenters for the pain they have taken to come up and present to us.
Yes, I think we
Thank
should
you,
appreciate.
Professor Kishore, and thank you, Rajarajan and AVS for bringing up such nice cases and having such nice discussions. We should also thank all the participants, principally the discussants also, without which it wouldn't have been so lively.
Okay.
Thank you all, sir.
Thank you. Thank you. Thank you very much. Thank you for giving me
Thank
the
you.
opportunity.
And next month, it will be from CMC Vellore.
Sir, okay.
They'll be presenting the cases. Thank you, Dhanraj, sir.
Thank you. Thank you very much.
Thank you so much. Thank you very much.
Thank you, sir. Thank you, sir. Ian, sir.
Thank you, Sun Pharma.
Thank you, sir. Thank you.
Ruben, Shanmugam,
Thank you,
all
sir.
of you. Thank you
Yes,
very
sir.
much
Welcome,
for
sir.
helping us along.
Yes, sir. Welcome. Sir. Always welcome, sir.
Thank you. Thank you.
Thank you.
Thank you.
Thank you, sir.